Hello, everyone. It's my fortunate opportunity to be able to capture you after sitting in place for about 5 hours, eating lunch, and then talking to you about the exciting topic of regulatory bodies and policies. So I'm going to earn the name, I hope, not of Ambien after this, because my goal is not to put you to sleep, but hopefully to engage you. And so I'm going to spice this up a little bit. And my intent is to go over digital health with you, because really digital health is the big revolution in medicine, the big revolution in health and wellness. It's our way of really being able to decrease costs, increase access, and really drive up quality. The promise has been there for a few years now. However, we've not really seen the impact yet because the adoption is not where it should be, the integration is not where it should be, and so the deflationary economics have not followed suit yet. But I hope at the end of this talk, I'll at least have you engaged enough to stick with the fact that this is going to be the future of medicine. This is going to be a key solution for us in driving down healthcare costs. I'd like to get an understanding of who my audience is a bit, so please, show of hands, how many out there are clinicians, physicians, nurses who are actively seeing patients? And I don't expect too many, but any digital health designers? So we have a couple. And then how many people in HR? I expected that to be the majority. How many of you are self-insured? That's great. I think the self-insured group is the ecosystem that's continually evolving and going to be the driving force to help us figure out how to drop healthcare costs. They're the agile group who can adopt these technologies and start to implement them right away, study them in small populations, and develop benchmarks. So a little bit about me. Why am I up here? I'm the Vice Dean for Healthcare Innovation at the University of Utah, and our approach is to solve unmet medical needs. Solutions are technology agnostic, so we'll work in the diagnostic space, device space, and then more recently in the therapeutic games and apps or digital health space. So I have a team of about 50 graduate students and 8 or 9 faculty working with clinicians and working with companies to create digital healthcare solutions across the entire domain. And as part of that enterprise, we incorporate intellectual property protection, but relevant to this talk, we have a specialized group who are experts in the regulatory domain, especially as it applies to ensuring that we're meeting FDA regulatory standards that are continually evolving. And one of the pieces you're going to get from this talk is it's a changing landscape. It's really early on, and the FDA has not quite figured out where it's going, as well as the other regulatory bodies who are integrating into this particular space. What is digital health? I think most of us look at it from the consumer-based perspective. And so we think about mobile applications, and we also tend to think about telehealth. And that's because this is how we interact and we acquire our digital health care. There are many other areas that are going to be more impactful than those 2 areas that we're looking at. And so I'd like to help keep you awake during this post-lunch event by talking a little bit about a couple of technologies that we've invented along the way. And so we're also looking at ways to train physicians and clinicians better, and we do that through digital engagement. And what you're looking at is a patient care video game that was developed to teach nurses how to care for patients, how to take care of IV sites, how to prevent catheter-associated infections. But again, most of us think about applications, mobile health applications and telehealth. And there are over 165,000 mobile health applications on iTunes alone. And this number is from 2016. We know that it's grown. 90% of these are free, and you get what you pay for. The majority of these have not had any medical professional input. The majority of these have no science behind them to really focus on user engagement and sustainability. Almost none of them have any validation and verification data to show that they actually work and that they actually make a difference. So in fact, it's digital noise more than it is digital health. And consumers aren't quite sure what it is they should use. Which one of these is going to really help them? They tend to focus on reviews saying, I downloaded it, I liked it, but not, it was impactful, it made a change, it helped me achieve my goals or the goals that I set with my physician or my healthcare provider to be able to actually make this a valuable asset to me. Now, the promise of digital health is actually far more expansive. This technology is virtual reality. And this is a video game that we created in a niche market, as academics frequently do, but an important market. So we worked with the end user, in this case, autistic children, to create a video game that helped self-soothe and helped reduce readmission rates for autistic children. And so the game was created by them. It was designed for user engagement, sustainability in its application, but also sustainability in its impact. And we are moving this through to get into the FDA realm because we are using this as a therapeutic, and that is one of the key factors that helps you decide, do I need to get through a regulatory body, or is the regulatory body going to ignore me and let me stay off center stage? We'll talk a little bit about regulation in more detail a little bit later, but please keep an open mind and don't think of regulation as a bad thing, because I think regulation is actually a very, very good thing for this industry. It's just got to be applied judiciously. Augmented reality is another solution very closely related to virtual reality, and that allows you to interact with your normal environment while superimposing a video-based or a digital-based image that allows you to take the two realities and merge them together. This video game also is an augmented reality piece, and this is our lead designer from the Therapeutic Games and Apps Lab. He is dealing with the critical issue of body dysmorphic disorder. So you come in as a patient who has a nutritional deficiency because you are concerned that you're obese or that you're large or that you're perceived this way, when in fact the rest of us see them as quite thin and malnourished, and this is a critical health issue. So what we've been able to do is allow the patient to construct what they think they look like, to be able to show it to the healthcare provider, and then we can take their real body image, real size in this real clinical setting, and put it next to what they see themselves as, so they can start to realize that it is a body dysmorphic disorder, that what they're seeing is not really how they appear to the rest of us. So augmented reality, like virtual reality, is going to have a key role, but it's not the major driver that we're looking for in the future. It's a piece of the puzzle to help digital health move forward. The real key is going to be in artificial intelligence, machine learning, major changes to the way we do telemedicine, and of course, blockchain. So blockchain, does everybody know what blockchain is? A few do. So blockchain is integrating everything together so that your health record contains everything from CVS Pharmacy to the healthcare provider you saw in Wichita with Stanford's medical system, so that you can see the entire continuum of care provided to a patient. And it's coming. And this is going to dramatically drive healthcare costs down. And the folks who are really leading the forefront of this right now are the US military and the VA. They're putting an inordinate amount of forces behind something called Genesis. And Genesis is already kind of in its first iteration, so you can actually look at a patient in the VA healthcare system, see their DoD records, and I can get data from a large number of commercial pharmacies that are putting that information in, so I can see, are they getting narcotics? How many narcotics are they getting from what number of providers and from what number of pharmacies? This is really going to allow us to drive down the cost of care. And so this is part of that spectrum of digital healthcare. Telemedicine is another key piece that allows us to increase access, hopefully at some point actually drive down costs. That's really not come to fruition the way we would like it to. But have anybody heard of what's going on in China, the internet hospitals? So China has developed internet hospitals, which is a new iteration on telehealth. And it's one that we're watching closely because of this experiment that's going on. And it's allowed access to care from across their nation, but it's implementing something on top of their current system. So a business entity has come in, and they're using the hospital structures that exist in Beijing and other major cities, but they're using a digital system to connect them to patients. And it's only been implemented since 2014 as a test bed. They've already generated over $3 billion in revenue. They've brought in hundreds of thousands of physicians and healthcare workers, and they're delivering care across the country, but they've done it in a way that breaks down and merges with the regulatory bodies so the barriers are not in the way. Again, we're watching this to see what the impact is. Because you have utilization and because you're able to capture patients that weren't getting care before, you assume that care is better, but we don't really know until we see what those long-term impact metrics are going to be. But not everything is perceived well in digital health, and this is why regulatory bodies are starting to get more enforcement into this particular area. You take a look at the comments of Dr. Mattis, the head of the American Medical Association in 2016 came out and said that healthcare applications are equivalent to 1860s snake oil salesmen. That what we're delivering is actually hurting healthcare. And a number of researchers are publishing on this data and presenting at national meetings saying, this is bad for healthcare, we're hurting patients, not helping patients. And it's hard to argue that to an extent this isn't correct. In fact, there were 4 app manufacturers who released applications that seemed pretty interesting on the face of it, and that was you could take a picture of a mole, and the application would go through an algorithm and it would say, this isn't cancer, or this might be cancer, you should go get seen. That seems very useful. I don't have to go see a dermatologist. Well, the FDA wasn't involved. They decided to go after a discretion on enforcement. So their enforcement discretion said, yeah, this isn't something we're going to pay attention to. Really don't have the time, and I think partially they didn't have the expertise to really understand it at the time. But then a group of academics studied these and found out that 30% of these applications were wrong. And is that a big deal? Well, of course it is. If you have a lesion that's a melanoma and your app tells you don't worry about it, and 3 years later you have metastatic disease and a 90% mortality rate, that's a big deal. That makes this probably a class 3 device based on FDA regulatory standards, certainly a class 2. So the FDA started to get more engaged. And in fact, they did it, maybe some people believe randomly. They would say they did it selectively. We saw them go after 23andMe. They shut them down. They shut them down for a period of time because they said, wait a minute, you're practicing medicine. You're taking people's genetics, that's okay. You're giving it to them, but then you're saying, well, there's this chance that you've got this particular disease. And they weren't quite sure how that was going to be digested by patients, whether it was going to lead to more problems. So they started to get more involved, and they really started to look at the digital health industry. But what they decided was discretionary enforcement was the way to go, and that the majority of these healthcare apps they were going to pay no attention to. They've got a relatively small staff at the CDRH, which is the subunit that adopted this technology for devices. And they had 165,000 applications out there that they would have had to go and grab and decipher, and they really hadn't had that figured out. The interesting thing is their guidance on this came out in about 2013. But in 2010, they had already had 260 complaints about digital health technologies that had malfunctioned, 44 injuries, and 6 patients had died. Yet they decided to practice enforcement discretion. And US legislature getting involved in policy also didn't want the FDA getting involved in this process. In fact, there were 3 House resolutions that were aimed at preventing the FDA from having discretionary or full enforcement oversight over digital health. And one of them finally got through, the 21st Century Cures Act. That was the 4th. So now the US Congress has said, we don't want the FDA getting in the way of this digital health revolution because we think this can have huge impact. So the FDA has had to stand back a little bit more. Other bodies started getting involved. New York Attorney General's office this year said, we see essentially quackery going on in the healthcare application space. And so they took 3 companies to court this year in 2017. One of those was a company that had been a subsidiary of Adidas. And all of them were using proprietary algorithms to measure heart rate in patients. What they found is the data was not always accurate. In fact, the accuracy was relatively low. There were medical applications assumed behind it. And so these organizations went to court. They won their case. The financial payout from these companies was actually just a slap on the hand. In New York, it was about $30,000. But it sent a message out to industry saying, we're going to keep an eye on you, even if the federal government is not. So between these events taking place and some other self-reporting that was taking place, big companies, and these are big companies, Pfizer, Sanofi, Aventis, coming forward and saying, we released applications into the market that are probably not safe. And the FDA didn't regulate them, but maybe they should have. For Sanofi, Aventis, they had an application out there for diabetics that helped them individually tailor their insulin regimen. This is essentially the practice of medicine, which is done by physicians. And that resulted in some malfunctions in their technology that were giving patients information on doses that would have been incorrect. And they saw this as a potentially life-threatening issue. So with these events that came forward, the federal government started getting involved again. In fact, if you look at the litany of regulation around digital health, it spans across the entire government enterprise, from the Federal Trade Commission, who got very heavily involved in digital health and took a number of companies to court in 2014 for deceptive business practices, noting that it did something that it actually didn't do, something we would think would fall under the FDA purview. The FCC also has oversight into this because we're using the internet technology to go across states and to go across nations. Health and Human Services is very interested in this because if you're collecting data on patients and you're a HIPAA-covered entity like self-insured employers are, you fall under ERISA and you are a HIPAA-covered entity, now you can have HIPAA violations that the HHS gets involved in. So this became a very complicated network for regulatory to try and figure out what to do. And if you go into the telehealth space, it gets even more complicated because you start to cross over into state issues. So now, if you're a physician and you're doing telehealth, are you an owner of the telehealth company? Because if you are, and you're referring, you may be violating the Stark Law. But in most states, the corporate practice of medicine policies, which are interpreted differently in different places, California, very, very difficult interpretations, that says that as a non-physician, you can't own a physician enterprise. And so how do you have an enterprise that's owned by a physician because it can't be owned by somebody else, but if you're referring to yourself through your enterprise, that you're violating federal law? And then we have the issue of crossing states and not being licensed to practice in those different states. Now, there's reciprocation in some states that have been involved. However, this complexity has become really quite problematic. The good news is the regulatory bodies want to step up and they want to help. So the FDA has come out with really substantial guidance on how to help through the process of developing digital health. They want to have you avoid the pitfalls. they also realize that since they are still practicing in discretionary enforcement of their policies through 21 CFR, that majority of the companies out there are going to make the determination on their own. Do I need FDA or do I not? And you just go to market and you practice. And if you got it wrong, they're going to come knocking on your door like they did with 23andMe. You don't come to them and say, do I need FDA clearance or approval? They're expecting you to interpret the guidance that they're giving you and to make an appropriate decision. So the FDA is really interested in helping, but it's going to inhibit innovation a little bit. So there's pluses and minuses with the regulatory oversight of digital health. If I am a medical device, a piece of software considered a medical device, I now have to go through verification testing, validation testing, ISO 13485, ISO 14971, and then there are a number of other international standards that have to be applied to software specifically. And as you can see up there, cybersecurity now becomes a critical issue for the FDA to weigh in on too. So it gets complex, and you have to have expertise to be able to do this. You can no longer be a couple of college graduates who know how to code, who can simply create something and put it on the internet and say, here you go. By the way, it may make some recommendations on how to help you specifically as a person prevent or treat your disease, because it's not going to fly. You're going to be violating the regulatory rules. So it becomes complex. The plus side is we're having high quality products come out into the market because there is regulatory oversight. And the FDA has now stood up a brand new unit that is specifically focused on digital health. Unfortunately, they note that it's only going to be manned at about 13 individuals to start with, and they're having a very difficult time trying to figure out how they're going to bring on experts in technology coding from especially Silicon Valley and be able to pay them a government rate that's going to be able to allow them to capture these individuals to work. Now, all of these oversight bodies have come together, and this is guidance by the Federal Trade Commission, and you can see on the bottom of this that the FTC, the FCC, the Office for Civil Rights, that's the oversight body with Health and Human Services who determines violations of HIPAA laws, and the FDA have come together, and they actually will guide you through the process of how to develop mobile health applications, what it is you need to do to stay out of trouble. Does it look like you're going to be regulated? And if so, what is it you need to do to be able to meet these parameters? So they're really standing up. I think regulatory oversight is going to be a good thing for us. We just can't get in. I didn't do that. We just can't get into the process of really inhibiting our ability to create great and impactful technologies through doing this. And we worry because one of the big pluses about the digital world is I can change it very quickly. If I've got a medical device, I have to go through a huge process to change the manufacturing of that. But what we've learned from the standard consumer-based use of digital media in general is that I can make a tweak to it, and you can look at it and as individuals, and I can track it and say, now it's being used more effectively, they like it better, let's go ahead and implement these changes. But with the FDA, when you get your clearance to market, that's it. That's your product. If you want to make a modification, you have to go back and get reapprovals or reclearance, depending on the process you're going through, which regulatory pathway that you're using. So there are going to be trade-offs. But I think from a human resource perspective, adopting these technologies and the advances that are going to occur in them are going to be critical for dropping your costs, improving your access, and delivering higher quality care. AI is going to be one of the big factors for us in the future. It's the regulatory barrier there is going to be difficult. So for the physicians in the room, we do an electrocardiogram. The machine spits it out, and we pick up the electrocardiogram and we read it. Now, for Rusty Hoffman, I hope, as a surgeon, I hope I'm a green dot. But regardless, I'm a surgeon. So when I pick up that EKG, if it's a standard EKG tracing, I'm going to be pretty good at interpreting it. But otherwise, I rely on that machine learning piece. When I pull it open, it says Patient has sinus tachycardia with left bundle branch block, otherwise normal EKG, and I probably wouldn't have picked up the left bundle branch block. I'm not a cardiologist. I don't read these all the time. But the FDA has said, to stay out of trouble, you can't really make the diagnosis. That information has to be validated by a cardiologist. So the realization of digital health isn't going to rely on, hey, digital health or AI, machine learning has made the diagnosis probably better than you, doctor, can make this diagnosis because it's pattern recognition and we're good at it. But you still got to give it to the cardiologist to say, yes, I agree. And so the billing hasn't changed, right? You're still paying that fee to get that extra piece done. We need to learn to overcome that. And there are going to be some specialties out there that I guess I wouldn't really want to be in the future, because pattern recognition is where this is going to have huge power. So AI is going to do a better job being able to read CT scans, MRIs, radiographs, pathologic specimens. Fortunately for the surgeons in the room, I think we're safe for a little while. But the power is there, the future is there. Regulatory bodies need to start catching up with where this technology has gone, and that's what's going to allow us to be able to really apply it successfully in the future. Thank you.